Kia ora koutou and welcome to today's webinar on transforming cancer care, co-designing chemotherapy prescribing and administration software. I'm Rebecca Macbeth, I'm the media editor at HINS and I'll be your facilitator today. I'd like to thank Valentia Technologies for sponsoring this webinar. So we have a fantastic lineup of panelists today. I'm going to ask each of them to just briefly introduce themselves, starting with Stephanie Crabb. Kia ora, Stephanie.
Kia ora. Thank you, Rebecca. My name is Stephanie Crabb, and I'm a Senior Project Manager at Te Whatu Ora Health New Zealand.
Thank you. And we've got Dean Croft. Kia ora, Dean.
Kia ora koutou katoa. I'm Dean Croft. I'm the clinical lead for the Raurau Ngaehe project. I'm a hospital pharmacist by background, had an interest in medication safety and clinical informatics. Nice to meet you.
Thank you, Dean. And we have Sarah Kennedy. Kia ora, Sarah.
Kia ora, I'm Sarah Kennedy. I'm the Clinical Nurse Manager for Cancer and Blood Services in Northland, Te Tai Tokerau. Originally from the UK, but I've been a nurse 20 years this year.
Great, and we're very lucky to have beaming in from the UK, so the middle of the night for him. Thanks for joining us, Kashif Rehman.
Hello everyone, thanks Rebecca. My name is Kashif Rehman. I am the Technical Program Lead and Product Owner for Raurau Ngaehe at Valentia Technologies. I am joining from Dublin, Ireland tonight. Thank you.
Great. So an exciting lineup. We are going to have presentations from each of the panelists, and then I will open up the floor for questions. So please do keep those coming in via the three dots button, the bottom right-hand corner of your screen. But first up, we're going to hear from Stephanie.
Okay, thank you. So I'm just going to start with a bit of background about the project and an overview of the system that we've co-designed. I became involved with Raurau Ngaehe, the regional haematology and oncology e-prescribing and administration project around 4 years ago during the COVID epidemic, when it became quite apparent that there was a need for an electronic prescribing system. Prescribing practices across the northern region at the time were completely paper-based, and it was easy to see the inefficiencies within the regional service, along with the lack of visibility, and it was difficult to prescribe remotely. The prescriber, so I'll just go through the primary objectives. So in moving to a digital solution, our primary objectives were to improve clinical safety, reduce errors, and improve legibility. Improve patient and clinician experience, support flexible regional care across the northern region and bring it closer to home with the use of the iPad. Prior to the use of Raurau, prescriptions were couriered to multiple sites, and now information is available simultaneously at sites. One of our key objectives was to improve data and availability of reporting. Of course, data captured in a paper-based world is unreliable and inconsistent, and there was no ability to track staging and intervention data. Creating visibility of the cancer treatment plan to the members of the wider care team, for example, emergency departments and non-cancer inpatient areas, as well as improving end-to-end efficiency in patient treatment. So the scope of the project, it covers 7 hospitals within the 4 districts across adult and paediatric oncology and haematology. We started delivering in counties Manukau last year, and we currently have approximately 900 users now and 2,500 patients on the system. We still are currently onboarding Auckland Haematology, and we plan to go to Auckland Paediatrics later in the year in October. After execution of a closed RFP, we chose our preferred vendor that best met the requirements for haematology and paediatrics. It was not an easy decision. We went with a custom build, wasn't made lightly, and we took that decision to several forums and external reviews for validations, as we knew it would be a challenge, more of a challenge than picking an off-the-shelf product. We're very proud of the decisions that we've made and the steps that we took to build the solution. And I think one of the key attributes to the success of the project was the fact that we had senior leadership and support from the likes of Dr. Richard Sullivan, Dr. Peter Watson, Lara Hopley, Dr. Carl Cole, as well as regional buy-in from the cancer network across the 4 districts. Just coming now to our system overview. It was a very complex system that we built, and there was a number of dependencies. And that's why it did take us at least 4 years to complete build and delivery. Technology was used, designed for accessibility. So we've used a cloud-based system. It's based in Australia. We have a number of FHIR APIs allowing different systems to integrate seamlessly. And we're utilising Azure single sign-on for user access. Just if you look at that diagram, we have some inbound integrations and outbound integrations. The inbound integrations in green, we have coming in for patient creation, we have the patient information coming from the demographics API. And we also have regional clinicians coming in via regional clinical portal. The labs integration brings in the most recent blood results from the Sysmix Eclair system. And on the left of the screen, you can see the Act Now protocols, the SNOMED CT diagnosis, and the Ta'aho o Takaho regime definitions, and the NZULM coming into the formulary. The outbound integrations we have coming out of the chemo admin side of the product is the patient treatment summary that goes into the RCP labs and also into 3M, which is a document repository for Auckland. We have the Baxters and Slade integration, which is the compounding information that comes out, and we have the New Zealand EPS and the Electronics Special Authority from the prescription side coming out of the system, as well as going to a BCP solution. And not to forget the CanShare and Snowflake data extraction that comes out as well of the system, which is really important and has improved a lot the data capture from the system. Raurau itself is broken down into 4 modules. We have the formulary protocol builder module, prescribing, pharmacy, and chemotherapy administration. The formulary is obviously where the pharmacists build the protocols. The prescribing component is where the doctors will prescribe from. The pharmacy is where they order, dispense, check and release the medications. And then we have the administration of the chemotherapy, which is on a separate application delivered to iOS on the iPad. As I mentioned, it's a very complex with a number of dependencies. So just wanting to mention and also that we had to set up a new API gateway that allowed our internal systems to talk to cloud-based systems. We had to set up a new mobile device management tool, Microsoft Intune for iPad security. We had several Wi-Fi upgrades, as this is a tier 1 solution that had to be set up for the hospitals, and a new trusted security wireless network that was put in place as well for the iPad connectivity. So that's it in a nutshell. Thanks, Rebecca, for the high-level design.
Great. Thank you, Stephanie. And do remember to keep your questions coming in using the 3 dots button in the bottom right-hand corner of your screen. It'll be great to go into a little bit more detail in the Q&A about some of those issues you talked about, particularly the interoperability. I'm sure listeners would like to hear more about the CanShare, the data sharing, and what that enables. And also, Dean might go into this as well, but you've obviously got some go lives yet to come. You've delivered to 900 users, which is exciting, and then you've got some go lives to come. So we are going to move on to Kashiv. Thanks, Kashiv. Take it away.
Hello, everyone. Thank you very much, Rebecca. I'll just give you a very little overview of what I'm going to talk about today. So we will take a brief look at our solution, exploring its architecture, underlying technology, and the benefits it offers. We will also discuss how we applied the Agile methodology using the Scrum framework in the project. Along with it, some of the challenges we encountered in delivering this exceptional product. My next slide will be in 1 second. Here you go. So, as Stephanie said, Raurau Ngaehe was conceived in response to the growing need for resilient healthcare systems, particularly for oncology and hematology services. The system was designed and developed by a cross-functional team of clinicians in the northern region, data and digital, and very committed development team from Valentia Technologies. As you can see, it has a very user-friendly interface, and I want to actually give you a glimpse of how the system actually looks like. So if I zoom in a little bit and just give you a few screens from the left, you can see the diagnosis interface where prescriber can go and add diagnosis for the patient. Then they can add a protocol and plan and prescribe treatment in this middle screen. And on the right-hand side, there is a pharmacy worklist screen where the clinical and operational pharmacy perform their actions in ordering and dispensing the medicines for the patient. On the bottom left, we have a pre-treatment checklist screen. This is from the iPad app, which is available to the nurses. So as part of the process, they do pre-treatment checklist complete to ensure a safe medicine administration. Then you can also see blood sign-off screen in the middle, and on the right-hand side, we have a patient chart where they can actually document the medicine administration. All right, so I mean, the application is designed and built in React. React is a cross-platform library, which is very handy when it comes to delivering an agile project. Okay, so next I would like to give you a overview of the architecture that we have behind it. So Raurau Ngaehe is a secure cloud-based SaaS solution designed using microservices architecture and managed through Azure DevOps, enabling streamlined and automated deployment process, making it highly available. So again, I would like to give you another glimpse of the different releases or the environments we have from dev to QA and to UAT and the production. So this is the whole automated process and which makes it highly available for the users without any downtime. The cloud infrastructure ensures scalability, reliability, and efficiency. The system at the bottom, you can see we have SNOMED CT, HL7 FHIR, which is some examples of the high ISO standards that we are using. The system conforms with various high ISO standards, including API, health record, interoperability, and security standards. And as Stephanie mentioned in her slides as well, that there are a lot of system integrations done in here. So Raurau Ngaehe is integrated with New Zealand healthcare ecosystems using FHIR APIs, which is an international standard for exchanging personal health information, and SNOMED CT ref set, which was published by Act Now. The integrations include, I think there are 12 or 15. Act Now, we have NZEF, New Zealand Formulary, Medicine Data Repository for dispensing information, Special Authority for prescribers to check the affordability of the drugs. Then we have data going out to BCP solution, so patient charts, pharmacy orders, and treatment summaries are downloaded to the laptops, which can be available if there will be a disaster scenario. Other than that, we have demographics, we have labs, we have regional clinical portal for data exchange. A user can redirect to Raurau Ngaehe from RCP, and also the treatment summaries are going back to them. We are also exchanging data with CanShare and the regional data warehouse. I mean, there are a lot of resources that we are sharing with them, such as patient demographics, observations, including BSA, patient height and weight, their ECOG status, creatinine clearance, diagnosis, care plan, including the regimens and cycles, patient prescriptions, medicine administrations, and pathological prognostics. The application is designed in React, as I mentioned earlier, and then we also have an iPad version of the app for safe medicine administration to access patient charts and document clinical notes on the go. Cloud-based functions offers features such as autocomplete for medicines that are being documented and chart locking and unlocking functionality. I mean, the benefits that we are getting with this architecture is that we have access to the solution from anywhere, anytime, streamlined workflows for medical professionals, minimize data entry time for them, enhanced clinical decision making, capable of sharing records within and across the regions, CanShare and data warehouse for analytics, and BCP service ensures patients on ongoing treatments such as chemotherapy receive uninterrupted care even in the face of disaster. Okay, so using agile methodology, the development of Raurau Ngaehe was highly iterative, involving continuous collaboration with end users, including clinicians, nurses, and pharmacists. This approach allowed the team to refine features and functionalities very quickly, ensuring the solution met the complex needs for chemotherapy prescribing, pharmacy ordering and dispensing, and documenting treatment administration needs. We used t-shirt sizing technique to eliminate our efforts to complete a task, using the relative estimation by comparing the size of one task to another, helped us better planning, prioritizing tasks, taking informed decisions, and managing expectations. We used multiple sizes of a sprint, but we calibrated to 3 weeks delivery at the end. We have used Jira as a management Scrum board to manage our backlogs, sprints, and releases, and Jira Confluence for requirements, meeting minutes, user feedback, testing, training, release notes, etc. And we use Teams and Zoom as the communication tool. Okay, on the go, we have a few challenges as well. So understanding the chemotherapy regimen and clinical jargons was a bit tricky in the beginning, but building this complex system solution from bottom up was quite demanding. And we overcome this, which is a great example of alignment between clinical team and the developers. We build a glossary of clinical terms with us. Then the other challenge was translating the requirements into system design. And then we had a lot of development challenges as well, which we can actually cover in question and answer sessions. Thank you very much for listening. And I will be very happy to answer any questions in the QA session. Thank you, Rebecca.
Great. Thank you, Kashif. Really interesting. And we've got some questions coming in, so they'll certainly get into that in the Q&A. Just a reminder that you can ask a question, and you can also see information about the speaker panel anytime by clicking on the 3 dots button at the bottom right hand of your screen, and you can select info for the speaker panel information or ask a question. So hopefully we will get to all your questions, but if you include your name and email address there, then we will be able to come back to you afterwards if we don't have time. As Kashif mentioned, there was a strong clinical engagement, user engagement in the development. So we are going to hear from Dean next, who can speak to this. Just before we pass over to Dean, I just had one quick question that's come in that you might just be able to answer now, Stephanie or Kashif, which is just, is the lab's view, is that a view of the Northern Region clear, or do you only bring in the labs you order, like a GP system, in terms of what you can view? Are you able to answer that?
Hi there. Yes, sorry, I was not on mute. Yeah, so we're just bringing in the relative blood results from the Eclair system, the patient blood results specifically that are relevant, that are used for required for prescribing, like the creatinine clearance.
I see. Great. Well, we've got a couple more. There's obviously some interest from some primary care people in this solution, so we'll go into that later. Dean, are you ready with your slides?
Kia ora. Yes, I'll share my slides in just a moment. I'll just talk a little bit first, if that's okay.
Perfect. Okay, thanks.
Thank you very much. So I joined the Raurau Ngaehe project first as part of the RFP process, and then as the clinical lead in April of 2021. I'm going to be talking a bit about the experience of the clinical team in working with Valentia and Data and Digital Northern to design, develop, and deliver the system. And the journey we've been on building something like this from the ground up really was an incredible lesson in the power of teamwork, but also in patience, perseverance, and on my part, humility. I've always felt like a bit of an imposter. I don't have a strong clinical background in cancer chemotherapy or haematology, so it was all learning. I'll share my slides now. So the first thing I would like to get across, the point I'd like to hammer home really, is that chemotherapy e-prescribing is hard. There are some unique challenges with chemo that general prescribing systems don't usually have to deal with. There is many different ways of dosing medicines. Our system has 20 different dosing types, from flat doses to calculation-based doses on body surface area, milligrams per kilogram, area under the curve based on renal function, rate-based dosing. And the weight you might plug into these formulas can also change depending on if the patient is, small or big. And chemotherapy treatment is usually cyclical. It can be both inpatient and delivered in an outpatient setting. Changes and modifications need to propagate through time. And the treatment can also be quite messy for patients. That these are potentially toxic medicines that do cause side effects in many patients. And there are often deferrals and dose changes and things that happen at the last minute. And the clinical workflow of the system needs to be able to accommodate all that kind of churn and change. So I think one of the keys to success here was assembling the right team of subject matter experts. We eventually ended up with 8 clinicians and 5 FTE. It was really important to find the right mix of expertise and regional representation, and also to keep the team relatively small, so we could work nimbly. We had a mix of SMOs, nurses, and pharmacists with haematology and oncology experience, and at least one representative from each of the Northern Region districts. In addition to the core clinical team, it was critical for us to be able to lean on an external working group, or MDT, from around the region, of which we had about 14 members. As Steph mentioned, we also had a really supportive senior leadership group that were hands-off enough to allow us to make decisions, but kept us on track, and were also supportive enough that we could take the sort of hairy clinical and scope questions to make sure we could have that escalation point. And this diagram is slightly anachronistic, having been drawn before Health New Zealand, but remembering when this project first kicked off in 2021, it was before FHIR was announced. And I've just included it because it really highlights the importance of having good governance in a project like this, and having a variety of groups that you can consult with and escalate to, depending on the issue or challenge that you have at hand. Moving on to the design of the system, in large part, we were very much guided by Valentia, who've got a lot of experience with the Agile design methodology that we embraced. Agile is not necessarily the best method for all types of projects, but for one of this size and complexity, I think it was really critical to success. Another remarkable thing that's probably quite passé at this point is that this kind of project wouldn't really be possible prior to COVID. Our team was collaborating across 4 northern districts and working remotely with Valentia across 3 different time zones. And we built the entire system in that fashion. And so during the days of DHB land, when working sort of regionally or nationally wasn't yet the norm, we really had to use the tools like Jira and Zoom and Teams to really help make that sort of possible in the first places. One of the perhaps unsurprising initial challenges we encountered when doing the requirements was that each region was pretty keen to mimic the process that they know, their existing paper workflows, and in practice, different sites and services had different business rules about who would do which part of the process. And one of the risks of designing a system in a group fashion like that is you can very easily come up with something that suits nobody. So we had to be very careful to make sure the system was built in such a way that it had the flexibility to allow steps to be completed sometimes in a slightly different order or by different kinds of users. We really wanted to make sure that the Raurau Ngaehe's workflows were well integrated with the existing clinical workflow that people follow on a day-to-day basis. Things like being able to issue the take-home EPS prescription or apply for a special authority directly from the prescribing module without having to go to a separate system. We also wanted to build the key safety elements that are an important part of chemotherapy process into the system. These are things like the blood and investigation sign-off, clinical screening by pharmacists prior to treatment going ahead, timeout checklists. So we look to systematize these safety features, but also in a configurable way. So the approach we followed on the advice of Valentia was really to start with some written requirements, of which there were 500 or so we documented in Jira, Confluence, and these were worked up through weekly sessions into Adobe XD wireframes and finally into an interactive HTML storyboard. We spent about 9 months on this process, which sounds like a long time, but I really can't stress how essential this iterative process was before we go into the costly development time. The other key to success I'd just like to highlight here was that being able for the clinicians to work directly with the developers as opposed to via business analysts or some kind of other intermediary was really key to get that engagement and alignment when we were both talking quite different languages, really, clinical jargon and technical kind of jargon. So we're very thankful to have the team at Valentia who really have embraced the agile mindset. They always graciously welcomed and accommodated our many change requests, some of which we discovered only after using the system to treat patients. And so this mindset is another really important thing that I'd sort of highlight in terms of doing a successful project. So after that design phase, we spent 18 months in development, going through what seemed like endless sprints to test and refine the system before we moved to user acceptance testing in May 2023. I think we're up to about 8,000 Jira tickets now. Our first site to go live was Counties Manukau Haematology, and we have to thank them for being game enough and brave enough to be the very first users, remembering that this was a brand new version 1 system delivering potentially very toxic medicines to patients for the first time. So as you might imagine, we had some pretty nervous stakeholders. We also had a number of outstanding known issues of lower significance with the system. So we were really striving to only do the must-have items and keep to MVP. And we managed this in a couple of different ways. The first one was really just through transparency, engaging with the county stakeholders team, sharing the full known issues list, going through it line by line with them to accept or escalate anything they felt like they must be done before we implemented. And we also started small with about 10 patients and gradually scaling up. We then moved to Whatu Haematology, which was a similar size, and then to Northland oncology and haematology. So we brought on the oncology patients and they're a bigger service as well. And then this year, we tackled the medical oncology at Te Tokatumai, which is the largest treatment centre in the country, I believe. They treat more than 80 patients every day. And just this week, we've started at haematology in Auckland, Te Tokatumai, which has more complex inpatient regimens as well as stem cell transplant. So just in terms of reflection, I think the keys to success were having a clear transition plan, preloading patients, having close at the elbow floor support, And just a shout out to the Data and Digital Northern training team, who were really amazing in both learning the system, delivering training, as well as being a core part of the floor support. Valentia were also very supportive, coming out to New Zealand and working night shifts in other time zones to be able to respond to issues quickly. And as you can expect, we did have a number of bugs and hiccups along the way. And really, just to finish up, this chart, which some of you might recognize as the Dunning-Kruger effect, really kind of summarizes my journey through the project. You know, initially we sort of swaggered our way up to the peak of what they call Mount Stupid. And then when we realized how deep the water was and how complicated building such a system would actually be, we were down in the valley of despair at some point. But fortunately, with perseverance and patience and a great team, we did make it up what they call the slope of enlightenment. And so here's just a few lessons learned. I won't go into these. Happy to ask any particular questions around the Q&A. Thank you very much.
Great. Thank you, Dean. I very much enjoyed those GIFs, and always very happy to see the Power Rangers appear on a PowerPoint slide as well. Adds a bit of fun into it. So just a reminder to the viewers that you can ask a question or even just pose a comment at any time using the 3 dots button at the bottom right-hand corner of your screen. And if you've joined late and want to see some more information about our panelists today, you can click info. But finally, we're going to hear from Sarah. Thanks, Sarah.
Kia ora, so I'm the newest member of the team of panellists to the Raurau project. I became aware of the electronic prescribing project when I was first employed in the Cancer and Blood Services here in Northland, Te Tai Tokerau back in 2021. And I was quite keen to become involved with this project, really, because back in the UK where I worked previously, I've had experiences of working with electronic prescribing chemotherapy systems previously, and was really impressed by that. That was my first experience of using an electronic prescribing system, so I was really quite keen to become involved with the project. So when we're looking at user experiences and our team in particular, I mean, I can't talk to the other sites, but I'm sure they'll be relatively similar. You know, it's better and safer to have all of our notes really in one place. We used to print off our blood results from RCP and put them into the paper notes. And we don't have to do that anymore. Those blood results are pulled through from RCP onto Raurau so that the check-in nurses can actually see those at the bedside when we're checking medications. Of course, there's no case notes that we need to sift through to try and find all this appropriate documentation, consent forms and treatment plans and scripts and all these things that we used to have to sift through. When we'd had deferrals, we used to have crossed out dates on the scripts, and that obviously we used the script again and just the next date was put on there. So that did sometimes cause, you know, confusion. No handwriting legibility issues. We've all seen doctors' handwriting, and at the best of times, it's hard to decipher. No queries around documented treatment doses. Again, you know, handwriting, when we're writing doses on paper scripts, that was a big issue at times, and that those doses sometimes needed to be clarified. Our clinic nurses and clinicians have these electronic notes to hand now, so they're not also searching through paper notes and having to locate notes if they've got patients either in front of them in clinic, or our clinic nurses taking phone calls from patients on a daily basis, potentially having to go and locate these notes before they can get the information required. So there's no requirement to send paper notes to Kaitaia. We run a rural service 1 day a week, providing chemotherapy treatments in Kaitaia, so that we can provide some local delivery of treatments closer to home for patients. And we had initially, when I first started in the role, we used to send the whole set of notes via the laundry truck up to Kaitaia. They used to complete all their documentation, and then they used to send them all the way back again on the laundry truck. Of course, that would create issues within itself. So the notes wouldn't arrive in time, the notes wouldn't be back in time for the next patient's appointments. So you know, that created lots and lots of issues itself. Then we decided we were going to scan and email the relevant documentation. They would complete it and scan and email it back again. But of course, we've got patients who are on weekly treatments, and scanning those backwards and forwards got, you know, quite difficult to see what had been signed and what hadn't been signed. So now they've got all those notes to hand on the iPad. So that's really streamlined that process and saved an awful lot of time for those scanning and sending back of notes. The nurses in Kaitaia can now raise queries as well on the Raurau system for certain clinicians to address, or it can be to a pharmacist, rather than having to try and email, and then people don't necessarily see the email. Urgent queries, though, for patients still do come via the phone. The real-time documentation, you know, there's access to the system anytime, anywhere. So if clinicians are at home and, you know, they've forgotten to prescribe a script, you know, we can call them at home and say, can you just get on the system and do the documentation that's required. Also, patients having the same day appointments, pre-assessments for chemotherapy with the doctors, and then moving down to the treatment floor, you know, that require the go-ahead to be given for us to proceed with treatment administration. We require that documentation in a really timely manner so that we can proceed with administration of treatment. And that now can be really easily done while the doctors are discussing that with the patients. We don't have to wait for them to write up their handwritten notes, put them in the notes, and then to bring the notes down to the treatment floor. So that's, you know, a real time saving exercise, certainly from a patient point of view, and they're not sat waiting for the notes. So that's definitely improved patient experience. I say easy use of the iPads. I would say now it's an easy use of the iPads. Initially, there was some, you know, less tech-savvy RNs within our department, and we're really quite skeptical about having to use the iPads versus the desktops, and they felt that it would actually potentially be unsafe or increase time. And I think initially, while they were getting used to the system and how that worked, it may well have increased our time, but actually, certainly now it's decreased our checking process and time. You know, there's definitely a reduction in delays from that point of view. Our change management process and integrating the system into our BAU was challenging, as the other speakers have mentioned, several challenges along the way, and we, you know, as with all changes, there were definitely some pushbacks and reluctance to the change. There was some minor workarounds about process changes, as Dean mentioned. Each region wanted to incorporate their own processes and not change their processes. But I think we kind of realised we needed to adapt our processes slightly to fit with the programme and to make it safer, actually. For example, we created for our deferral patients an email address which incorporated a global email address, so it included the relevant people who needed to know about the deferral. And that's actually made our communication between our relevant teams here much improved. I think adequate training time was quite underestimated by us. The actual training for the system potentially was 2 hours, and potentially our nursing staff certainly needed longer than that. So the amazing training team put on some drop-in sessions for everybody to attend, and that wasn't just the nursing staff, that was for all clinicians as well as pharmacists to attend, and that gave them a chance to raise queries or question things that they weren't sure about within the system prior to go live. And of course, we were the first site to go live with medical oncology patients as well. The first 2 sites were haematology. So our clinicians had a lot of approval processes to go through when the scripts were transferred across. And I don't think we factored enough time for them to have in order to approve everything that they need, as well as continue to run clinics and provide the service. I think the phase out of paper notes has been a challenging process as well. I think when you're quite used to paper, you quite like paper, you know, but some of our clinicians also prefer to handwrite their notes, and that's still evident, you know, today, and we are working through that. But sometimes we do have to remind our clinicians that, you know, things are now done on the system, but, you know, mostly things are run really, really well. I think we do still use some paper notes for some of the protocols that are not built within the system as yet, and also patients who don't come under oncology, for example, our rheumatology patients who we treat here as well, are on paper scripts at the moment. But I actually can't imagine going back to using a full paper system now. I think most of our staff have really embraced the change and are continuing to embrace the changes. And I really look forward to the day that we are a completely electronic based system and we don't have to have any paper notes. And I think my final take home really is that if every person in the process does what they're meant to do, the process runs very, very smoothly. And I can absolutely see in this system being rolled out in other areas aside from chemotherapy. Thank you.
Great. Thank you so much, Sarah. So we have some questions come in. The first one is if someone could please talk about how you've ensured that the data captured can flow between systems and can be reused. For example, the role of SNOMED, and you know, what is the impact on the wider health sector of being able to share that data between systems? Do you want to start on that one, perhaps, Stephanie?
Sure, Rebecca, I'll leave as the technical way that it flows through the systems to Kashif. However, just from a design perspective, we can talk through the fact that the solution was designed in collaboration with Te Ahu Te Kahu to utilise the national Act Now regime definitions, the New Zealand ULM and the SNOMED CT to support the use of FHIR-based integration. So this increases the capture of national cancer data. And this development has increased Act Now data coverage nationally from 40 to 70%, which supports the study of treatment outcomes.
Perfect. And presumably when you have that data flowing around the system, it allows you to interrogate it, analyse it, take action on it as well to see where improvements might be made or where there might be gaps in the system.
So there's the CanShare integration, which is specifically, you know, data that CanShare requires to do their analysis. We also have, as I mentioned, the Snowflake integration, which is a regional data repository in the Northern region, and that any of the Northern region operational data centres can pull from to pull reports on anything they'd like, which makes it a great more readily available to look at patients and treatment outcomes.
Great. Did anyone else want to jump in on that data sharing aspect and the impact that that has both in the Northern region, but also more widely, having that information flowing and available?
Yeah. So I would like to add some comments onto this. As I mentioned in my talk that we are using the ISO standards for data capture and data exchange. We are using SNOMED CT, which is a clinical terminology language, which is nationally and internationally understandable. We are also using FHIR APIs, which is again a national standard for data exchange. So from the data capturing point of view, again, the data set that we are capturing conforms with the ISO standards. So I mean, you know, and we have very good examples here. The data share across the region is also accessible within the system, but at the same time, we did a full proof of concept with CanShare, where we capture all the data and then we call the API developed by them, which is a FHIR API, and exchange all that information for data analytics. So that is one part of it. The other part is basically where we are exchanging data using the Parquet files. We are dropping our data to S3 bucket, which is then picked up by Snowflake for data consumption and for showing the analytics. So following the standards and you know, following the international technologies such as SNOMED CT and FHIR makes it easily data available to within and across the solution.
Perhaps, sorry, if I could just jump in very quickly, just to mention on the clinician side, I think this has the potential to be transformative, but we are at the beginning of a long journey here. So the clinicians really don't want to be having to be the ones to enter, become the data entry technicians for this technology. So there is a whole vision that Te Aho Te Kahu has from getting the diagnosis and histology from a clinical pathology report into Raurau Ngaehe, where we can also capture the outcomes as well of the treatment, and tying that all together will be, I think, when we really start to see the potential. But it's been really exciting to see the progress made so far.
Right. Another question, if someone can just talk a little bit about what documentation is available. They've put, for example, care plans and risk assessments. Is that something you can cover as well, Dean?
Yeah, sure. So starting off with our MVP, we have a progress notes feature, which really lets nurses and pharmacists and prescribers do their kind of day-to-day type notes, which is particularly useful in the outpatient setting. The other thing is we've built based on EVQ, anti-cancer basic patient assessment, which covers the general toxicity, things like that. We've moved vital signs into the system for outpatients. And I think we've identified on our roadmap for improvement is lots of users have requested additional assessment tools and things. And so what we really need is some kind of form builder where the users of the system can develop their own, assessments and documentation tools moving forward. So as the MVP, we have those few things we mentioned.
Thank you, Dean. This one might be for you, Sarah. It's just asking, how is it used by the inpatient service giving chemotherapy, and how are notes shared between inpatient and outpatient services?
I think that's probably more of a one for Dean, actually. We don't have an inpatient service here in Te Tai Tokerau, so that probably be able to speak to with the Auckland implementation.
Yeah, so we are delivering chemotherapy on the inpatient ward, and as you can imagine, you have existing either e-notes or paper documentation, depending on the district, around the progress notes and the vital signs and all those ancillary documentation features. We really thought it was quite important to not try and double up, documenting in two systems. So each site has really come up with their own business rules around what stays in Raurau and Ngaehe and what gets transcribed. But for the most part, those sites that are already using a inpatient, either e-notes or paper documentation system are keeping everything together in one place rather than siloing that information.
Thank you, Dean. A couple of questions here, like I said, related to kind of primary care. One was, are you connected to GP records for classification lists such as allergies? And the other one, is there any single click in context connected to GPs for the patient's enrolled practitioner? Can anyone talk to any connections into primary care? Kashif, is that something that you can just, it might be on the development list, I'm not sure.
Yeah, I mean, at the moment, we are basically not directly getting feed from the primary care system, but I mean, we are sending a feed out to the primary care system in a sense of the prescribing that we are doing for outpatient prescriptions. So they are integrated with the single page prescribing tool, which is basically that any outpatient prescription actually also be visible on the GP system or the single page prescribing system that that these medicines are being prescribed in hospital. So there is a one-way traffic at the moment, but yeah, I mean, again, one of the thing that we have on the roadmap is basically to send the treatment summary to the GP systems through the system. Thank you.
Great, thank you, Kashif. So, Sarah, you did talk about you know, adoption and having some less digitally literate staff. And I just wonder if you can talk a little bit more about how you enable them to use the system. And I think you might also have a few quotes that you collected from staff. I'm sure a bit of a user view would be nice as well.
Sure, I can share my screen now for those comments, which yes, I did collect from our team members. Can you see those okay?
We can.
So I think looking at how did we you know, enable staff to use the technology. It's a difficult one, really, isn't it? Because with the implementation of the project, you know, they didn't really have a choice. It was coming, and they kind of had to use it. So we just made sure that there was enough training. I think the amazing training team that came up and really supported us through the implementation. Not only dedicated training for each specific user type, but they also put on those drop-in sessions that I mentioned earlier, which gave those nurses potentially that felt a little bit less confident with the system, were able to go and maybe have a one-on-one, or, you know, take a specific query to the team. And we were also really lucky that one of our pharmacists, our lead pharmacist, was part of the setup and part of the Raurau team. So we had her on site available 4 days a week to go and ask queries. And also post implementation, there's certainly resources that have been put on our intranet, so they're available for us to go and refer to should we need them. And there's a Raurau support contact number, which is a cell phone that's manned by one of the Raurau support team, which we've had to call on a few occasions. So that's really helpful to get through to somebody immediately, rather than trying to get through to IT and then trying to get that directed to the right person to answer any queries that we've got.
Great, thank you, Sarah. I've got a really good question here, which I guess will have some universal lessons in it, which is, how did you handle having such a wide range of input into this project with a range of different processes and still manage to reach a consensus on an approach? I think a lot of people will want to know that one. Who would like to start on that?
I guess I'm happy to have a go. So we had a lot of disagreement internally in our team when we came to first, designing the system, and it's not easy. I guess the best thing to say. I think the key really is making sure that you have an environment where everyone can share their opinion within reason. Also bringing in external people from our clinical working group and taking kind of decision or brief decision documents to them. And then finally, there were a couple of conundrums. One example was how we were going to manage the transcription of some medicines to the inpatient chart for patients admitted for chemotherapy, and there was just no right answer. So for those really hairy ones, we basically lent on our team of senior leaders, people like Richard Sullivan, Lara Hopley, and Carl Cole, and we got them to make an executive decision. So I think that's more or less how we managed the disagreement. And I guess it's probably not perfect, but that's the way it goes. I think when you have to choose these decisions that are grey.
Do you have something to add there, Stephanie?
No, I think we did do obviously current day process mapping. That was something we started with the clinicians, and we did have a regional team that before the project was set up that was involved with the RFP on the design. So we had a layered approach to the design perspective, but then as we onboarded clinicians onto the project, as Dean said, he had in a sort of a little small group of a team that really sort of got into the nitty-gritty of the design to really sort of cut it down and argue it out between them. And then that went up to the senior leadership. So it was a great layered process, I think, that we had to map those processes and starting with counties and then rolling out to Waitemata moving forward as we sort of aligned the processes from a base through all regions.
Thanks, Stephanie. Kashif, this might be for you. What are some of your future plans? How will you continue to support and develop this solution?
So we have multiple things on our future roadmap, including advanced data analytics and use of AI-driven decision support tools. There are a few more integrations that we have in mind as well, such as for scheduling. And I mean, there is a global expansion that we are looking at as well, because since we go live in the northern regions, we have seen significant interest in the product both in New Zealand and internationally, which is greatly welcome. However, our immediate focus is on developing a patient app. A patient app is the natural extension of Raurau Ngaehe. Our commitments and goals are always patient-centric, and developing a patient app will close the loop, providing direct value to the patients by empowering them with access to their treatment information, enhancing engagement, and improving overall care outcome. As you say, the baby is born, and we are committed to nurturing and meeting its needs as it grows.
Mm-hmm. Thank you, Kashif. Yeah, talking about patients, I think the last question is really if we can bring it back to that, what is the impact for patients? What does this enable for patients now and into the future? And I know, as you mentioned, Dean, the next go live is paediatrics, and obviously that's moving into a different sort of group of patients, I guess, children who I believe are quite unique when it comes to cancer care and chemotherapy. So perhaps you could start us off on that one.
Yeah, sure. So this was a highly technical solution, largely focused on the workflow of clinicians. However, we have developed in the system a patient medication card, which is sort of front-facing, and that can be used as a source of information about when their chemo is happening, blood tests, and some information about their chemotherapy. We did some consumer engagement on that. So we look forward to kind of starting to use that feature more often. The other thing that Kashif mentioned is a patient-facing app. I think that would be a really useful thing as well, to get some of that information out to patients. It wasn't part of our original scope because there are other initiatives, like our CCC, which were looking to deliver, this kind of information sharing, of which we would expect to eventually be part of. So we're very pleased to hear that Valentia is keen to work on the patient-facing app, and I might go over to Sarah for this, but I do think that the fact that the system can make local care delivery and hub and spoke type care delivery more streamlined. That's on the business side, but I think if anything that makes that easier, it may be an enabler for patients to start having care closer to home.
Yeah, Dean, thanks. Completely agree. I think the few things that we've certainly noticed here is that we feel our safety check-in process has been improved, which is only a good experience for patients as well. Although we did have stringent, safety check-in processes previously, now that all the notes are in one place, we're not having, as I mentioned, sifting through those paper notes, printing those bloods from RCP. We could just pull those through. Improved legibility, less room for error. I think that's certainly improved safety for patients. I think the check-in process has now become faster and easier, so that each time a different nurse checks for a different treatment for a patient, for example, it's not a whole process of having to go through the whole set of notes again. It's readily available to hand on that iPad, and certainly the notes process through to CanShare is significantly improved our experiences, and I'm sure their experiences as well. And when we look to open our hopefully unit in Bay of Islands, hopefully towards the end of this year, that will the same will be in place there, that we have got the iPads and the accessibility of those, that documentation. I think, you know, the Act Now protocol changes as well that we upgraded to during this process did actually mean that some of the chair time and some of the script length was shortened. Some of those additional fluids were taken off certain regimes, which has actually meant that patients have less time in our chairs and more time to themselves, especially those patients that do have to travel from out of town. It's quite difficult timing wise for them to, you know, for scheduling as well. So it's actually made that a little bit easier as well. And, you know, less time in the chemotherapy unit. We're quite aware nobody wants to be here. So if we can reduce that time for them at all, then we will do. And I think another big thing as well is the visibility and transparency, you know, when patients attend ED. A lot of oncology patients do get side effects from treatment, and sorry, I've just got a tannoy announcement in the background. When they do attend ED, especially in the rural hospitals as well, Kaitaia and Bay of Islands and Raurau as well, they have a read-only view and also can access through RCP to see what treatments have been given. So that's made decisions around care much easier when patients have attended and arrived in ED.
Well, thank you so much, Sarah, for bringing home the real world benefits for patients as well as nurses and clinicians such as yourself. It's been such an interesting discussion, but I do have to wrap it up. So I want to say thank you so much to our panelists, and thank you to our sponsor, Valentia Technologies, and to all of our viewers for joining us today. And thank you for supporting HINZ. If you're not already a member, you can click on the HINZ logo at the top left of your screen or go to hinz.org.nz. Mā te wā.